All right, good afternoon, everybody. It's Mike Shimmons, Executive Director of 3RNet. Thank you for all of you for coming today. Looking forward to a very lively discussion and a lot of information from the Bureau of Health Workforce. Melissa Ryan is here with us, and her title is on the first screen here. I'm going to have her talk a little bit more about her background because, as we were discussing a few minutes ago, she has been with this office more or less for a dozen years or more. So we're looking forward to her expertise and just to hear what else coming down the pike. There is a lot going on in the Bureau of Health Workforce, as most of you know. And if you don't know, you will find out even more today. We'll let Melissa do her presentation. You can put your questions in the chat. We'll try to feed them in if we can. If not, we'll hold them to the end and try to get all of this done in approximately an hour of time. So we really do appreciate the opportunity to hear from Melissa and the office. And we would have had them out of Bozeman, but again, we were held back from that this year. We will try again next year. So, but thank you, Melissa, for being with us today. And I'll let you take it from here.
Wonderful. Thank you so much.
Thanks so much.
And I would love to come to Bozeman sometime. So I look in the future. But as Mike said, my name is Melissa Ryan. I'm the Director of the Division of Policy and Shortage Designation at HRSA's Bureau of Health Workforce. And as he said, I've been doing workforce for quite some time. I have been in the Bureau of Health Workforce since its creation in 2014, I believe it was. It was actually created by the merger of the Bureau of Clinician Recruitment and Service, which I was in prior to that for several years, and the merger of the Bureau of Health Professions, which I had worked in before I moved to the Bureau of Clinician Recruitment and Service. So I've been doing health workforce since 2009, and actually I think even a little bit before that. So it is something that these are programs I've been working on, like I said, for about a dozen years or more. So we'll go ahead and get started with just kind of a really brief overview of the Bureau of Health Workforce and what we do. Talk about the ARP, the American Rescue Plan, and the funding that came to us through that, what we've been doing to respond to COVID. Talk a little bit about our loan repayment and scholarship programs, as well as our other workforce and career development programs and shortage designation and kind of what's coming down the pike. But I really want to say, because a lot of people think of Bureau of Health Workforce and they think about shortage designation, they think about the National Health Service Corps, those loan and Nurse Corps, those loan and scholarship repayment programs, but we run over 40 programs out of the Bureau of Health Workforce. So those are really huge programs and incredibly important. There's so much more to what we do. So just to give you a really quick overview, as we all know, the healthcare sector is sort of a major economic and labor driver in the United States. And we're projecting that employment in this area is going to increase about 14% through 2028. And because of that, it's creating, it's a great growth area, but it also means that we have a shortage of providers. We don't have enough providers. There's also a shrinking supply because of retirements, especially in rural areas that many of you know. A lot of the rural providers are retiring. And again, I don't need to tell you that the distribution of providers across the United States is unequal. There are times where we talk about having shortages, and when you look at studies, there actually isn't necessarily a shortage of that type of provider in the country, but there are extreme shortages in specific geographic areas for those provider types. And that coupled with the rising costs of education and the COVID-19 pandemic, which we're only, currently sort of starting to, grapple with what that means for the health workforce. There is a lot going on in our space right now. So how do we actually get students to go to work in rural and underserved areas throughout the United States? And the research shows that training students, where students train and where they're from, are two of the biggest, are really the two biggest drivers of where they actually end up practicing. So we are looking to recruit the students from communities that we serve. We're looking to train students, even if they're not from that area. We want to train students in rural communities, in community-based settings. And so that's why, we're actually we're trying we're making a concerted effort to focus our programs on where we can drive people to community-based settings for training. We're also leveraging our loan and scholarship programs to try to do this, training people in interprofessional and collaborative teams, and looking to integrate both behavioral and oral health into primary care. And, you know, we're really looking to shift away from, you know, training and those sort of tertiary institutions to that sort of boots on the ground type of training that will encourage people to actually stay in rural and underserved communities. So we're uniquely positioned to address these workforce challenges. So in supporting community-based training programs that encourage our clinicians to work in rural and underserved areas, we're looking to grow a skilled healthcare workforce to improve the health of people in high need areas. And, you know, our programs allow for sort of the innovative and flexible responses that our nation needs to address its emerging healthcare challenges. Our programs are designed to positively affect every aspect of a health professional's career, from education and training to service in the community and to continuing education. And I would even say even in the pipeline, because we even have some pipeline programs to try to encourage young people to go in to health professions and make them attractive. Wanted to give you a little bit of an overview of our programs. So about 57 million people, about 18% of the population, live in rural communities. And as you know, they face unique challenges for health status, sometimes, and largely due to gaps in healthcare infrastructure. And they are bearing the brunt of both the COVID-19 and the opioid pandemics right now. And so to address these disparities, you know, we're looking to invest in bringing doctors, nurse practitioners, physicians assistants, all different types of providers to rural communities who need them the most. And we do that this is just a little bit of data on our providers in rural areas. So between the National Health Service Corps and Nurse Corps, we have over 6,000 providers who are actually serving in rural communities and have an obligation to the US government to serve in an underserved area. And particularly in the National Health Service Corps, about a third of the providers, and sometimes it can be a little bit more than a third, sometimes it's a little bit less, but it usually is around a third of the providers are actually in rural areas. Our advanced nursing education nurse practitioner residency program, we're really, really proud of this program and what it's looking to accomplish in providing training for nurse practitioners. And at least 40% of the training sites are in rural areas. We also have, you know, greater than 50% of our residency sites in rural areas for the Rural Residency Development Program. And our Teaching Health Center graduate medical education program, more than 90% of our providers are training in medically underserved or rural communities. And we also are working on the behavioral health workforce. We have multiple programs actually working on behavioral health workforce. And, you know, more than 50% of those people are getting trained in how to treat substance use disorders, and many of that are focused not just generally on substance abuse, but also on the opioid epidemic. So this slide gives you a little bit of an idea of what our budget looked like. On the left side, a little bit of an idea of what our budget looked like before the American Rescue Plan. We had all of, you know, and this is by no means an exhaustive list, but it is, you know, because there are several programs that run under some of these lines. So these are just sort of top line budget numbers. But we had a budget of about 1.67 billion before, and the American Rescue Plan gave us another $1.5 billion. So our budget literally kind of doubled overnight, excuse me. And this gives you an idea of where that $1.5 billion was dedicated. So 800 million of it was for the National Health Service Corps. 100 million of that 800 million is actually dedicated to the state loan repayment program, which many of you may be aware is actually open The application cycle for that is open right now. It is open and it is going to be open through April 8th. So please, ensure that your states are looking at that and aware of that. We had $330 million of investment for the Teaching Health Center's graduate medical education program that funds residency training in teaching health centers. So again, trying to drive folks towards that community-based training. We had $200 million that came to Nurse Corps and $100 million that went to our behavioral health workforce education training programs as well. And then we had this 80 million and 40 million. And this was really brand new programming that came about as a result of the American Rescue Plan. We'd been talking about figuring out how we could do some of this work around what we're calling provider resilience and providing support to health workers out there who are, they're being traumatized by what's happening in the COVID pandemic and what they're seeing and what they're dealing with. And so we have an $80 million program that was completed, or $80 million specifically for providers and really to provide training. And so it could also be training in residency programs and in educational settings. And then there was another 40 million that was specifically to go out to providers to provide it for their actual workforce. And we'll talk a little bit more about that in a little bit. So again, we've been doing so much work as a result of the ARP to actually bring a number of programs online and invest the monies into our existing programs. We basically have obviously it was a huge amount of support for the National Health Service Corps and Nurse Corps. It has resulted in the largest ever field strength, which is providers serving in the field for the National Health Service Corps ever in the history of the 50-year history of the program. And it also allowed, the ARP, not just the ARP, the CARES Act prior to the American Rescue Plan provided $15 million for us to improve telehealth capabilities over the 150 different organizations that we work with through 5 of our programs. Telehealth has been huge. It was a big deal in the rural community prior, but the COVID pandemic really has pushed it front and center in terms of getting different organizations to realize that they really need to start working in this arena. And so that $15 million really helped in sort of helping our programs start thinking about providing more training through telehealth and virtual technologies. We also, the American Rescue Plan has allowed us to sort of deploy evidence-based strategies for more mental health and behavioral health providers through the behavioral health workforce and education programs. We don't actually know entirely what the impact is yet of the COVID pandemic on all of the health risk factors and on our health workforce. So we actually are funding research projects through our health workforce research centers to fund, we're funding studies about it because we think that this is obviously an important issue and we want to ensure that we understand it. And particularly the extreme burnout that our providers are facing. So we look forward to getting results of that study to help us in the future, help direct funding and our programs to help deal with some of the fallout from the COVID pandemic. Oops. I think I accidentally skipped a couple slides there. But back to that workforce resilience piece. So in September, we actually closed out the application cycle for all 3 of the programs that focus on provider resilience that I'll go into in a little bit more detail. But it was these 3, the 3 names of the programs are here: the Promoting Resilience and Mental Health Among the Health Professional Workforce, the Health and Public Safety Workforce Resiliency Training, and then we also put out an application for a technical assistance center to help the grantees of those other programs. So the first one, the promoting resilience and mental health among the health professional workforce, we are expecting to make 10 awards totaling approximately $29 million. And again, this is to help, our organizations actually establish programs to help, provide treatment and services to their own health workforce. And so this could be really any entity that provides healthcare was eligible for this. And that was, whether it's federally qualified health centers, private entities, but also health provider associations. So we're all eligible to come in for this funding. And we're still in the process of reviewing those applications in order to make those awards. Likewise, we're still in the process of reviewing the applications for the supporting the resiliency training. And so this, we were looking at we're about 30 awards totaling $68 million. And again, this was to do actual training efforts to build resiliency among the health workforce and the public health, public safety, professions. And so again, it was slightly different eligibility criteria, but this was a little bit broader in that it could be schools, academic centers, state, local governments, tribal organizations, and any appropriate public or private nonprofit that was interested in doing this kind of work. And then we're looking to award the one technical assistance center for about $6 million to actually tailor training and technical assistance to the grantees of those two programs I just mentioned. And so we are really excited. I wish I knew off the top of my head what date we're targeting for those awards, but I don't recall off the top of my head, but we're really excited about these programs. And so, at the agency level, we've also, HRSA has been a leader in the field of telehealth. As you know, our colleagues in the Federal Office of Rural Health Policy have really been promoting telehealth technologies for healthcare delivery and education and information services for decades now. And this is a key issue in rural areas. And as I said before, last couple of years has made it abundantly clear that the use of telehealth really transcends geographic boundaries right now. It's not just a rural issue, although it is still an incredibly important issue for rural. But we're seeing the value of telehealth absolutely everywhere. And as I mentioned before, in the CARES Act, we received $15 million in additional funds to specifically strengthen access to telehealth and distant care services for providers. We awarded that funding to, I believe, 159 organizations across our five of our health workforce programs to increase their capabilities during COVID-19. And we're hoping that it actually helps, increase our capacity to train current and future health workforce providers in virtual settings and simulations and prepare them to actually provide telehealth services themselves. But we know that's going to have its challenges. We've heard from our stakeholders that, the transition, while they are transitioning, there have been some challenges, largely in the infrastructure readiness. We know, that our grantees had a wide, sort of varying degrees and wide variability in their ability to shift to telehealth and teletraining, so to speak. And while COVID accelerated their shift, we still heard a lot about, issues with security and equipment, the cost of providing the actual equipment and training, and also a lot about the regulations and how the federal government has taken steps making to the provision and receipt of care through telehealth easier. And the healthcare providers, have said that they may use popular applications to deliver telehealth as long as they're sort of non-public facing, but rules regarding that delivery of care, being relaxed, it was incredibly helpful. We're seeing increased flexibilities, and we still are having to sort of juggle program requirements with those additional flexibilities. But it's an exciting time, and there's a lot of work going on related to this, and we're excited to see where it takes us in the future. So we'll go on and we'll talk a little bit about our loan and scholarship loan repayment, excuse me, not loan. I always jump on people when they say loan. We do some loans in our organization, but not in this particular thing, but our loan repayment and scholarship programs for the National Health Service Corps and Nurse Corps. So as you can see here, we had 100 and I think that's actually a little bit of a typo. It's 1.23 billion in ARP funding. That was our not 123 billion. If it was 123 billion, we would be in a very different place right now. But so sorry for that typo on the slide. But 1.23 billion, and then 289 million for our Nurse Corps programs. And I think, as I said, the really great thing about this is that, it's created a historic field strength of providers who are actually, obligated to serve these underserved areas. And actually, at least a third of them, year in and year out are actually serving in rural areas. And so, these are boots on the ground, people providing needed care to communities. And I think, that's why they're the most popular programs among most of our programs that people know about, because they are so out in the community providing the care instead of, training and focusing on that training aspect. So, and as you can see from 2016 to 2020, our field strength has increased for the NHSC by 50%, which is significant. And it had increased even in 2016. It was, I think, the largest it had been at that point as well, ever in time. So it continues to grow. We have our behavioral health workforce programs. Again, these programs are training professionals and paraprofessionals both in treatments to increase access to services in rural and underserved communities. And this increase, the suite of programs supports several initiatives to enhance quality of education and clinical training in behavioral health, and increase the number of practicing behavioral health professionals. So at least 7,300, so over at least 70% of our trainees in these programs are receiving training in medically underserved communities. So that means areas that are designated as health professional shortage areas, or medically underserved areas, or medically underserved populations, among other high need areas. As a result, over 40% of our graduates plan to continue to work in these high need areas. And given that growing substance use crisis, the fact that over 50% of the trainees have also gained experience in dealing with substance use disorders is really crucial through this program. So our primary care medicine programs, we have the primary care training and enhancement, the medical student education, and the teaching health center graduate medical education. And so we have a large number of trainees that come from disadvantaged backgrounds. And again, more than half of these trainees are going into medically underserved communities for their training. And at least 74% of them say that when they go through these trainings that they still plan to practice in primary care after they're finished with training. We have also looking at sort of the ends, either end of the lifespan. We have our geriatric and pediatric programs. Our geriatric workforce enhancement program is almost $43 million. And our children's hospital graduate education program is about $350 million. Again, more than half, 63% of the GWEP graduates plan to work in medically underserved communities after they graduate. And our THC GME trainees are also, a pretty diverse group. And I think the thing that's really interesting that many people don't realize about our Children's Hospital Graduate Medical Education Program is that, this really results, we train through our annual funding, 43% of all general pediatric residents in the United States get funding from us through this program. And over half of all of the pediatric subspecialty residents and fellows in the country also are funded through this program. So it really is a crucial program in serving our youngest in the population. We also have our nursing workforce development programs. This is a whole suite of programs. But again, we have 41% who are of the trainees in these programs are from disadvantaged backgrounds, and over 60% of them of the trainees are actually training in medically underserved communities through these programs. But the programs run the gamut, but they have as some of their general aims increasing nursing education opportunities and advancing nursing and supporting advanced nursing education, as well as improving the quality of patient care, increasing retention and strengthening the nursing workforce. And they do that through interprofessional training and practice, academic and clinical partnerships, as well as long-term clinical practice in community settings and the residency programs. So we also have a number of oral health programs. Again, we're very proud that we have a significant number of trainees from disadvantaged backgrounds, and that 100% of our postdoc graduates that go through these programs plan to work in the primary care settings. So these programs, excuse me. Sorry, I realized that I advanced the slide there. So, and when I say it's 100%, it's not just, it's not a small number. We have about 234 people that are actually looking to stay in primary care dentistry. And so that's exciting for us. It means that we're meeting the mark, at least for that program. For public health workforce and development programs, we fund the public health training centers. Those are 10 regional centers who provide all sorts of training to public health workers and health workers that aren't specifically public health workers throughout the country. And of those, again, we have a significant number of underrepresented minorities as trainees. Over about 60% of our trainees are trained in medically underserved communities. And more than that, the 68% plan to continue to work in medically underserved communities in the future. We have career development and diversity programs. We have a health career pipeline and diversity programs that focus on recruiting and retaining and supporting health professions trainees from disadvantaged and underrepresented backgrounds. These programs really succeed by providing access to high quality career pathways, clinical training experiences in rural and underserved communities, and curriculum development, particularly around evidence-based strategies, as well as things like scholarship support. So these programs include our Area Health Education Centers program, our Health Careers Opportunities program, and our Centers for Excellence, and the Scholarships for Disadvantaged Students program. So these programs, have reached over 335,000 participants last year. We also want to highlight a little bit about a health professions education and training initiative we've done. As I said, a lot of people focus on the National Health Service Corps, as well as the Nurse Corps, and when they think of the Bureau of Health Workforce. And we are incredibly proud of those programs, and they're very effective programs. But as you can see from the last several slides I've gone through, we have so many more programs than that. And they really are focused on trying to increase health professions training in rural areas, in underserved communities, in community-based settings. And so, we've really been trying to drum up that and get support, but we can't fund those programs unless there's actually people out there willing to run them. And so we actually worked with our primary care associations to develop a tool called the Readiness to Train Assessment Tool. That is something that was already deployed, but it can be used by organizations to kind of take a look at where are you if you're thinking about developing a training program, if you're thinking about developing a residency program, where are you sort of on the continuum of readiness to actually create such a program and implement it. And so we put out $5.8 million and went out to our state and regional primary care associations to actually, fund this to take a look at, how many people have actual actionable workforce implementation plans for these sorts of programs. So we're looking forward to getting the results of that. We've seen some initial results, but we know that more are coming. We also, as many people are aware, have run the shortage designation program that the health professional shortage area designations are required for the National Health Service Corps in terms of providers have to serve in a health professional shortage area. We also designate medically underserved areas and populations, which, sort of collectively, all of these types of designations are referred to as medically underserved communities generally. And our health professional shortage areas, it just is a little bit of a refresher, are, really focus on looking at a shortage of providers, and that can be in dental health, primary care, or mental health. And we can be looking at the shortage of providers in a specific geographic area for the whole population. We can look at it in terms of a subpopulation within a geographic area. So maybe there are enough doctors generally to serve everyone in the area, but however, there might not be enough providers who actually serve people on Medicaid within a certain area. And then there's also facility designations. And we've been undergoing over the last 8 years a project that we call the Shortage Designation Modernization Project that has gone through many steps over the last 8 years. One was creating sort of a new online system for our state primary care offices that are our partners in that to submit applications and to track data. In 2017, we updated all of our geographic and population HPSAs for the first time all at once in that actual new system. And then in 2019, we added in all of the automatically designated facilities into that system. Prior to 2019, our automatically designated facility HPSAs were all done on Excel spreadsheets via email, and it was not in an online system. There wasn't a whole lot of transparency. And so we remedied that. We put them in our system. And now there's significantly more transparency and about, what is that score that you get based on? What is the data, the specific data that it's based on? And when was it done? And, so actual individual sites can even go into our system and see what their score is. And then last year, the end of 2020, we put out two RFIs, one specifically asking for feedback on how from all sorts of stakeholders on how we could improve the scoring criteria for our health professional shortage areas. As many people know, we award National Health Service Corps loan repayment awards based on HPSA scores, and sort of we prioritize the awards, the applications for award in order of HPSA scores and several other things, but primarily HPSA scores. And so we're looking at how can we actually look at our scoring criteria and make sure that it is better reflective of the need that's really out there. And then just a few weeks ago in September, we actually did another update, and that was an update, of all of the health professional shortage area designations. So the geographic, the population and those automatically designated facilities were all updated a few weeks ago. And so that was the first time in history that that all happened at one point in time. And so we're very excited about that. So looking ahead, we have, we're looking to sort of gauge health centers' readiness for training. And we're looking at ways to actually address clinician well-being as we go through the COVID pandemic. We're looking at maternal health as well. We are implementing, we have sort of in the challenges here, the maternity care target areas is the MCTA, MCTA. And that is, there was legislation passed that we have to, within primary care HPSAs, essentially identify maternity care target areas and use those maternity care target areas instead of primary care HPSAs as the driver of how we prioritize our awards in the National Health Service Corps for providers, so OBGYNs and certified nurse midwives who provide maternity care services. So we're taking a very solid look at that to try to address the disparities in maternity care and maternal health throughout the country. Obviously, COVID has continued to be a challenge, and the already existing community needs that were there even before COVID. And we're still looking at, updating that scoring criteria for the health professional shortage areas in order to better reflect the need that is existing out there in the communities. Just wanted to put in a plug for a couple other things that we have in our Bureau. So the National Practitioner Data Bank, our work in BHW goes really beyond the grant, scholarship, and loan repayment programs. This is one of the areas where it does. And so it's a web-based, the National Practitioner Data Bank contains information on medical malpractice payments and other adverse actions related to healthcare practitioners and providers. And as of, I think it was December of 2019, the NPDB had over 1 million adverse action reports, almost 500,000 medical malpractice payments reports. And also we had, tens of thousands of judgment or conviction reports as well. And this is really designed to allow providers, when they're credentialing healthcare organizations, when you're looking to hire new providers and credential them, we just want people to check and use the actual analysis tool and data that's available to you to ensure that you're getting a high quality provider and to come serve your site. We also have the Health Workforce Connector, which is a place, it originally started out for the National Health Service Corps, but we now have Nurse Corps sites in there. And so it's really to help, but it's grown even beyond that. It really is looking to just provide a platform where sites who have career and training opportunities as well as actual jobs can put up profiles for their sites online. And certainly Nurse Corps and National Health Service Corps providers use this site to try to find jobs, but so do people who are not in that. And so it really is sort of a free advertising of your any opportunities that you have. And we really encourage anyone who doesn't have any site that wants to be on there and meets the criteria, who doesn't have a site profile, to put one on there to get the word out about their opportunities. We also have our National Center for Health Workforce Analysis that does original research on provider shortages and does the sort of sufficiency research on sufficiency, geographic distribution, and they produce and disseminate a lot of public use data, including our area health resource files and our national sample survey of registered nurses, among others. So we highly encourage you to look into their reports about many different provider types, and those are all available on their website for you to download and take a look at. And here's some of the other data. Not all of this is that we have available through the BHW. Not all of this is NCWA data. The area health resource files are definitely put together by our National Center for Health Workforce Analysis. But we also have clinician dashboards up that show you data on our National Health Service Corps and Nurse Corps alumni, where they're serving now, even after they have finished their obligations. And so that has great data about our retention, and you can play around and with that and slice and dice our data quite a number of different ways. One of the things that I've found most interesting, because I hear a lot from rural providers and organizations that people come in through the National Health Service Corps and then they automatically leave. And our clinician dashboards actually show that that's not totally the case. If you actually look at, from, I think the data in the clinician dashboard starts from 2012 through, I believe, 2019 or 2020 right now. And if you actually look at National Health Service Corps providers who served in a rural area, an overwhelming majority of them are still in rural areas now. But at least 5 years out, half of the providers are still serving either at the site, in the census tract, or at least in the county where they did their National Health Service Corps service. So, and that's 5 years after completing the National Health Service Corps obligation. So that's just, I highly encourage you to take a look at those clinician dashboards. We also have our field strength dashboards that show our current providers who are currently still obligated to serve and where they are. And then of course we have the shortage designation as well for the HPSA find and a lot of data on those shortage designations. So really quickly, some upcoming dates and deadlines. We have, as I mentioned, the state loan repayment program has an application cycle that closes on April 8th. And that is open for application right now and closes then. We also have a comment period until November 26th on our maternity care target areas. We have that FRN out there that actually proposes what our criteria are for the maternity care target areas and what we're looking at in terms of actually scoring those. And so we really encourage you and any organizations who are looking for that information to take a look at that and give us comments and feedback. We also have our National Health Service Corps loan repayment program and National Health Service Corps substance use disorder workforce and the rural communities programs, as well as the Nurse Corps loan repayment program. Those application cycles are not yet open, but they are opening very soon, sometime this fall. It's a lot earlier than we normally open them. We normally open them in January or February, but we are looking to open those up this fall. So please make sure that your stakeholders are aware of that. And we highly encourage you. We were able to fund down to a HPSA score of a 3 for the National Health Service Corps this last year. So we highly encourage everyone to really make sure that their communities and their stakeholders are aware that those are opening up, and that with the funding that we have through the American Rescue Plan, we will be able to fund a lot of people who might not have been competitive before, and we really welcome those applications. So with that, I will open it up for questions. I'm sorry, I know it was a lot of material, and some of it is my expertise and some of it not always, so I apologize for any slip-ups I might have made, but I'm happy to answer whatever questions you have.
Thank you so much, Melissa. That was great. Was a lot of information, and folks, I think I've muted everyone, so please feel free to unmute yourselves, ask a question, pop something in the chat. While we're waiting for folks to do that, I have a question, and I think it's just something I haven't seen in emails or information sent out there, but you talked a bit early on about telemedicine. And I know there's a potential big bill working its way through Congress right now of President Biden's. I think I've seen something in there, but I know they're cutting that. So I'm not asking for speculation, certainly. But my question is on broadband access. So, you talked about telemedicine, how important that is for rural, and I think that's so true, but we still hear issues of broadband access, just not in rural communities or the cost. And so I'm curious if there's been funding on that, or if you know of any funding included in a package.
I don't off the top of my head, because most of those, we focus on sort of what's going to come to us to implement. And while we agree that broadband access is obviously a huge issue for telehealth, it's not something that would come to BHW more likely than not to actually implement.
Oh, sure, absolutely.
Yeah. So that is unfortunately a little bit outside of my wheelhouse and my area of knowledge.
Sure.
We certainly recognize that it is a huge issue.
Yeah. I do see a couple of questions in the chat here. If an award is made to NHSC at a level as low as a 3 or similar rating, would the recipient be able to keep the award as long as the site does not go lower than that 3 during the placement?
So I'm not sure whether we're talking, so when someone's awarded, when we're talking about a National Health Service Corps going to someone at a site with a 3, that's for the loan repayment program, right? The scholarship program is it has different requirements, and every year we have to, we're legally required by statute to look at, we have to provide a scholar placement score that basically is sending people to what the highest need areas, which is what's required in the statute. So for the scholarship program, every year around April, we put out that whatever that minimum HPSA score is. And that's really a function of how many scholars we have and how many actual job opportunities are out on our Health Workforce Connector for National Health Service Corps providers and the HPSA scores of those sites, because we actually are supposed to, by law, ensure that there's at least 1 job opportunity for every scholar, but no more than 2 job opportunities for every scholar, or not job opportunities, entities. So that an entity could be a provider organization, it could be a health center network that has many different sites and many different jobs. But no more than 1 entity, or no less than 1 entity per scholar, and no more than 2 entities per scholar in terms of, what is sort of the realm of consideration for where scholars can go. So if you're talking about scholar placement, that's how scholar placement works. But when it comes to National Health Service Corps loan repayment, that's the cycle that we're opening up. And that is the cycle where, our last loan repayment cycle, the lowest, we actually, I believe, awarded everybody who was eligible, who applied for loan repayment, and that lowest HPSA score that came in was a 3. So we are in a position where we can award much further down that sort of ranking in terms of HPSA scores than we have ever been in my recent memory. And because, in previous years, we were saying we were kind of cutting off at depending 15, 16, 17, sometimes 18, where we would just run out of the funding. But we certainly have a significant amount of funding through the American Rescue Plan, and we are hoping that we really encourage everyone to tell everybody that is thinking about it to apply, because it should not be, I don't want to hear, I don't want to hear, because I heard it last year, we don't want to hear, oh, my HPSA score is too low for a National Health Service Corps loan repayment award, because it wasn't last year, and we hope it won't be this year as well, because of the funding that we have.
Great.
Christine, this is Jed. Can I ask a question?
Absolutely.
Okay. So, yeah, I thank you, Melissa, for your presentation. This is Judd Mellinger-Blount from the Pennsylvania Association of Community Health Centers. And I think you did clarify what the person was asking. I think sometimes people think that if they get this award and they have a super low score, a HIPSA score like a 3, that the next year they're going to lose that award if they slip to a 2 or something like that, which would only happen if they got rescored. Right. So that
Yeah.
award is for 2 years and can't be taken away
Yeah.
for something, for a HIPSA
Yeah,
score. It could be taken away
as
for some other
long as-
reason, but
Right. And,
You know.
and we don't pull National Health Service Corps providers out if the HIPSA score goes down. Like if it met the requirements at the time that the person was awarded or went there, then that person, as long as they stay there, is fine to complete their service obligation. Where it would be a challenge is if that person then decided that they wanted to transfer, or if you move them to another site that maybe doesn't have the same HIPSA score, that can be a challenge. It just means that they have to meet, as long as they meet the requirements at the time they go, they're not going to get pulled out. National Health Service Corps isn't going to say, hey, oh, your HIPSA was a 5 this year, you got awarded and now it's down to a 1. We're going to take you out. No, we don't operate like that.
Okay.
They do have to meet the requirements at the time they're going. So if the person goes to a site and they stay at that site for their entire obligation and it met the requirements at the time, whatever happens afterwards we essentially allow them to continue their obligation there as long as it met the requirements at the time. It's just that if they were to move to another site or someplace else, you would have to check in with the National Health Service Corps to make sure that the site that they're moving to, even if it's within your network, still meets the requirements.
Right. Okay, thanks. But I guess I have a comment and then a question. And the comment is that, I think it's the expanded funding for loan repayment is a huge improvement. That's really great. And I think one of the problems, and this leads into my comment, is that we're going to have a hard time. I'm going to work my hardest to get all my FQHCs in Pennsylvania to submit, to get all their providers to submit and to finish their application, because I saw a presentation last week where 600 applications were not even completed for NHSC loan repayment, and these are people who probably would have been funded if they would have just finished their application. I think that was the number they gave on the Today with McRae thing from BIPIC, but. So that's that, but I think I'm going to have a hard time convincing people to do that because they just saw their HIPSA scores in Pennsylvania just plummet. And I think that's really what they're thinking about right now. And we have one primary care site in Pennsylvania now that has a 20 and qualifies for National Health Service Corps scholar at this point, if the score stays at 20. And I guess my comment is I would like to see, I wish I had a better feel nationally for how Pennsylvania compares. And I do a little bit because we got a Pennsylvania summary and I got a national summary, and I know we did much worse than the rest of the country, and I'm not sure why. Well, I kind of have my inklings, but we won't get into that right now. But I would like to see that some sort of a better feel for nationally how we did. But here's my question. Is there a way that PCAs, now PCOs can do this. I don't think state offices of rural health can do this, but PCAs, I can't get into the portal and answer my members' questions because I can't see anything I can't see anything. Put it that way. And my PCO is great to help out, but it would be really helpful. And I can't put jobs out. I can put jobs in 3RNet, but I can't put them out on the Health Workforce Connector for my members. So a lot of the jobs are not out there. Is there a way that we could consider, and this has been brought up to Dr. Padilla too, is there a way we can consider some sort of, maybe just minimal access for PCAs where we would have an opportunity to get in and help our members more, be able to see the portal, maybe not make any changes, maybe not, dirty our fingers with, mess up your data with us, but a way to get in there and have a little more access so we could be a little more help.
Yeah, I mean, I don't know the answer to that. I'm not going to tell you that I do. It certainly would require some significant, development in terms of IT systems and creating something that was specifically for the PCAs. And I think the challenge that we face is that, particularly our state primary care offices, they are our grantees, right? We have a cooperative agreement with them, and that's why they have access. And a lot of them are submitting data to us, as I actually see a couple of their faces on camera right now. They're submitting data on providers to us, and a lot of them, for them, some of that is proprietary data that they're creating through that. So I don't know that we would be able to do that, but I certainly hear your request, and can take it back and have those conversations to see if it's a possibility.
Okay, thank you.
I see another question in the chat here, Melissa. With the increase in NHSC funding, will there be another application cycle for new sites to apply?
So there's a new application cycle every year. We always have that. I believe the next application cycle is opening at the beginning of next year, but not until usually I think it's after the actual the application period for the National Health Service Corps. I would have to check on that.
Okay. Okay. So as far as your understanding goes, it sounds like if someone is not an approved site right now, they would miss out for this next funding.
I think so, but I don't know the answer.
Okay.
Sure.
Okay.
But there is always an application cycle every year. So it's always important. And I think that's one of the sort of the challenges we have with our messaging. I think a lot of sites tend to say, oh, my HPSA score is low, so I'm not going to get anything. So I'm not going to bother to do this. However, that's not always going to be the case, because, HRSA will award as many people as we have the money to award, right? And so when we get increases in funding, that means that we can award more. So I just think it's really important to encourage sites, regardless of their HPSA score, to always, maintain that that relationship with the National Health Service Corps, to do their site applications, even if you're not immediately getting something because of situations precisely like this. But I will double check on when the actual site application is opening.
Okay, thank you. Let's see here. With increased funding, are the award levels being reviewed to be increased?
Well, there is a statutory limit on how much we can actually give. But at this point in time, we're not looking at increasing the award amounts. The award amount, it's up to $50,000 for National Health Service Corps, for 2 years for the traditional loan repayment program. For the rural communities, it's actually up to $100,000 for a 3-year commitment. And for the substance use disorder, it's also a 3-year commitment, but up to $75,000. So there are, depending on the program, there is the opportunity to do increased loan amounts. So, since we're talking, this is 3RNet, if you're talking about someone looking at, they don't know whether they want to do national, if they might qualify for the rural communities, or they might qualify for the SUD, or they might qualify even for the National Health Service Corps, I think that's, something that the providers should take a look at and balance, which one I might get more money if I go through this program. And our Nurse Corps program, it's not a set amount like the National Health Service Corps of $50,000 for 2 years. The Nurse Corps program, for example, actually will pay back a certain percentage of someone's outstanding student loan balance. And so for some individuals, going to the Nurse Corps, if they're eligible for it, is actually more financially beneficial. The drawback is that the Nurse Corps program, the awards are taxable, which is not the case for the National Health Service Corps. So it's just something to keep into consideration as you're advising professionals in your states.
Okay, thank you for that. I see a couple of comments in here. Our network coordinator from Oregon just shared she agrees with Judd. Participation in specifically the NHSC job fairs on behalf of their sites would be helpful. So I'll just leave that with you. Let's see here, Tom Rauner, safety net sites may also be eligible for NHSC SLRP funding as states are being allowed to offer funds next fiscal year without matching funding. So keep that in mind. Let's see here. Some folks have to jump off. Thank you for joining us. I did see a question earlier. As folks are jumping off, I'm happy to stay on as long as Melissa's available. We did have a question earlier about slides. I will share the slides and the recording with everyone. I'll put that out on the 3RNet listserv later today. Let's see here. I'm just gonna make sure I didn't miss anything. All right. Any other questions? Anything for Melissa? Well, we've got her on the line here.
Everyone can see my info, I hope. So feel free to reach out.
Yes. Thank you so much, Melissa. I know Mike had to jump off to another call as well, but we really appreciate your time and expertise. We greatly appreciate you taking so many questions from us. And just thank you. Thank you for your work and for giving us part of your day today. We appreciate it.
Thank you. I appreciate it. And send any additional questions, and I'll try to get back with you about the site application cycle as well.
Sounds great. Sounds
All right.
great. Thank you
Thank you so much.
All right. Thank you, everyone. Take care.